Well, good afternoon, everybody. So delighted to see you all here. This is the initial event of the Greater Lawrence Family Health Center Speaker Series. We are delighted that you are here. I've met many of you either before or just moments ago. You're from so many different places and so many different interesting organizations. And that's exactly what we were intending. We really want to have a discussion in Lawrence, about the issues that this city and community faces with respect to making the community and its citizens healthy. We can do this. We kind of know what the issues are. We just need to carve out time and space to have a dialogue. And so the speaker series is a little bit of a misnomer. It's called a speaker series, but it's really, again, about having a conversation, bringing into the community people who have backgrounds and knowledge and experiences of their own rights that may or may not be from Lawrence, but really setting the stage for talking about things like health equity, like food insecurity, like homelessness or being unhoused, like restorative justice. These are some of the topics that we will be engaging on in the rest of the series. Hope it's a monthly event. We'll take time to make sure that people have their vacations and the like. Um, our attendance today at our first session is probably impacted by the fact that in a few more days it's Independence Day. So lots of people, my staff included, who are somewhere between New Orleans and Maine. So we'll keep motoring along with our attendance as it is. But again, the intention is really to be in dialogue, and we'll continue to evolve this. Let me say a few words about myself. I'm Guy Fish, President and CEO of the Greater Lawrence Family Health Center. Sometime next week, it'll be exactly a year since I started at Lawrence. Thank you, and it's been truly it's been my pleasure getting to know this community, getting to know the health center, getting to know my staff, but most of all, the people of the Merrimack Valley and understanding their needs and how we can help improve the health of the community. And I'm really focused on that word community because that's where it all began as a health center movement back in the 1960s with Jack Geiger understanding that the kinds of things that he saw that were health care in Lesotho and South Africa were really about things like digging latrines and putting screens on and the doors and the windows and helping people to find useful work so that they could pay for the basics and the essentials. So much so that when he actually came back to the United States and did another rotation in a little place called Mound Bayou, Mississippi, he saw the same conditions. He saw people hungry, unsheltered, minimally sheltered, without the resources to care for themselves and their loved ones. So he started a clinic like he saw in South Africa. Imagine that. And he started taking care of people and helping them understand how they could raise their own crops, feed themselves, develop a farm collective, uh, and of course took care of the medical things, but that wasn't really the majority of the health needs there. And that actually stuck in the craw of the then governor of Mississippi, who came driving out to Mound Bayou to berate young Dr. Jack Geiger. And he said, how dare you give food away to these people? That has nothing to do with healthcare. To which young Dr. Jack Geiger said, well, excuse me, Governor, but last time that I checked my medical textbooks, the therapy for malnutrition was food. So here we are, and here we stay. That's the work. The work is looking upstream to the things that cause people to eventually become sick. And there's a lot of work in unbundling and examining what those drivers of healthcare are. We call them social determinants, also social drivers of health. And one of them is something called health equity, writ broadly. And so our guest speakers today Mr. Juan Fernando Lavera from Beth Israel Leahy, who's the Chief Diversity and Equity Officer there, and Mr. Michael Curry, who is the CEO of the Massachusetts League of Community Health Centers, will help us understand how to think about what is the definition of health equity, why does it matter, how does it manifest, and we'll get into a conversation, the three of us, initially around that, but then open it up to you because again, this is a conversation. It's about Lawrence. It's about Laurentians. It's about what are we going to do in our community to lift the health of the community. Um, my background, I actually practiced medicine for a number of years. I'm an MD, internal medicine trained. I was young and not terribly smart at a period of time and started my first clinical experience after residency in a small town of Milford, Delaware, which induced me to come there with a income guarantee for the first year. And so I went there, and my wife and I started a practice. Ran the office, and I saw the patients. And that was pretty idyllic. Very, for those of you who are old enough to remember, very Marcus Welby for a long time. Until it wasn't. Until reimbursements start to change. Medicare, Medicaid, private insurers all start talking about something called capitation. And, coming straight out of medical school, I had no concept, no basis, no training in thinking about the economics of a practice in a different model other than you look at a tonsil, you put down a code and they give you dollars for that, right? So how do you change over to capitation? Are you going to lose your shirt or make out like a bandit? Who knows? But eventually my wife, who's far more brilliant than I am, said, I've done the math. This is not sustainable as a solo practice. You need to either join a large group or hospital or figure out something else to do. And the more we scratched our heads, the more we realized that neither one of us knew enough about business at the time. So I drew the short card and ended up in business school. We went back to New Haven, and I was at Yale School of Management for 2 years. And that led to a very long journey through all kinds of interesting sectors in the healthcare industry, all based on innovation, new drugs, new devices, new diagnostics, consulting to these companies, investing in some of them. But in parallel, I also kept a very active engagement in the nonprofit world, and eventually got on the board of Beth Israel Deaconess Medical Center, got introduced to their community health center, which is called Bowden Street, was executive coach to a newly elevated executive director there for 4 years. I had a Friday morning conversation with a young African-American woman, first time in the corner office, coaching her for every Friday for 4 years. And in the process of doing that and also getting to know Demick Center through some other work, I began to realize at a stage in my life where the kids were all graduated and launched and the mortgage is well enough under control that I had some choices what I wanted to do in my life. And one of them was remembering the lessons of my youth, which was my parents, who were always community engaged and community active, and realizing that with the background that I have in healthcare and economics, business, there was plenty of opportunity to do some good in some great places. So enough about me. I think we need to get back to today's topic, which is health equity. Before turning it over to my speakers, one of the things that I've learned leading up to the pandemic and through the murder of George Floyd and beyond was the power of personal narrative, of describing in intimate detail to others an experience that you've gone through, because that's how we connect as humans, through that raw experience and what we unbundle from that. So I'm going to tell you quickly 2 stories that when I think of health equity, these are the experiences that I think of that are really painful to me. The first, back when I was young and not so smart, I was a second-year resident at Cleveland Metro General Hospital. Cleveland Metro General was a 1,000-bed institution taking care of people who had no other resources, couldn't go to the Cleveland Clinic, couldn't make their way into University Hospital. It was Greater Lawrence Family Health Center on steroids. And as a second-year resident, I had ER duty every once in a while. So for the month I was down in the ER, seeing patients, triaging patients, admitting patients, and this man comes in who doesn't speak much English, but clearly looked like he was in discomfort. So I evaluated him. And when I did his examination, physical examination, got to his abdomen, and he was tender in what we physicians call McBurney's point, which is sort of indicative that this man has appendicitis. Now, he was about 70 years old and Latino. And again, the language was an issue. But I ordered the lab work, ordered an x-ray, set that all up, and called a consult, a surgery consult. 40 minutes later, the surgical team comes down. Now, the residency program was not very diversified at that time. And the team came in and took a look. They talked to me. They took a look. They did a cursory exam, and they decided that, we don't think it's appendicitis. It's probably gas. It's a medical issue. Send him to the floor for some enemas. And I said, no, this is appendicitis. He's tender at McBurney's point. His white count is elevated, and he's in pain. Please admit him to your service and do what you need to do. They refused. So I did what I had to do. I admitted him to the medical floor, and the medical team watched over him, but later that night, he perforated his appendix. Then the surgical team came back because he was decompensating, took him off to the OR, opened his abdomen, cleaned out the abdomen with the pus that was around the appendix and the large bowel, and closed him up and sent him back to the floor. He died 2 days later. And I carry that with me. There's an old saying from Ben Franklin that doctors bury their mistakes, right? So I carry that with me as an example of the inequities in our system, because these surgical residents that came down had a very different view of patients who were not like them, who assumed that they basically, as Latinos and Latinas, are always complaining of pain. If I heard that once, I heard it 100 times. Oh, they always exaggerate their pain. It's part of their culture. Well, appendicitis is a part of everybody's culture. You need to do your job. You need to take off the blinders. You need to be able to provide the right care to the right people at the right time. Second story is even a bit more personal. I was a little bit older. We were expecting the delivery of our third child, who decided she was coming on the very night that there was a going away party for me in Delaware. And at this going away party, since I had no more clinical responsibilities and I knew all the nurses and it was over a nurse's house, my wife was there, some of the doctors were there, I was having a grand time. And they understood that I happened to like single malt, and there was a lot of single malt there. So about 11 o'clock at night, my wife tells me that she's actually in labor. And again, I'm about 4 sheets to the wind, right? So I am useless, right? We eventually leave the party. We go back home. We try to arrange for babysitting for our 2 older kids. We had a 4-year-old and a 2-year-old. And got that squared away, got down to the hospital. Now, the OBGYN service that we had, she had been seeing the doctor there, her principal doctor, had 2 partners, and deliveries were whomever was available. Unfortunately, earlier that year, during one of the visits when she was seeing one of the other covering doctors, he didn't see her. He didn't see her. He actually got offended by some comments. I mean, physically, he saw her. We went into the exam room, but he didn't see her as a person worthy of his attention and his care. She's a diminutive Vietnamese born woman who is, again, smarter than I am, ran a medical practice, did medical research in cardiology. And so when she questioned this doctor about, well, where did you go to medical school and the like, that was offensive to him. She had no right. And so his care to her during the term of confinement, meaning the 9 months of pregnancy, was never what we really wanted. We preferred the other two. But guess who was on call that night when she was delivering? I'll cut to the end of the story, which is that, again, me being a physician and looking the way that I do, but also being now three sheets to the wind by the time 6 a.m. came around, she never got the care from him that she needed. And when her physician finally showed up, close to 20 hours into her labor, she was exhausted. They actually ended up being able to do a vaginal delivery, but I almost lost my wife and my daughter, newborn daughter, that day. She came out, and for those of you in the medical trade, her APGAR scores was like 1, which on a 1 to 10 scale is just like that far from dead. She's now a PhD candidate, fortunately, in marine and ocean sciences, and she's working for Cory Booker in DC. So that turned out okay. But he did not see her, and he withheld his professional services because to him she had offended him. She had no right to question him that way. So when I think of health equity, those two stories come to mind in terms of access and availability of care, of being seen as worthy of your attention, of not having bias, and uh, and frankly, racism enter into the equation for who's getting what care and why. So I call upon all of us to think deeply about these questions of how do we deliver care? What is it? What is the care that we want to have for our loved ones? Why is it different in one location than another? These are age-old questions in American healthcare. Why is the C-section rate 20% in one location and 2% in another? These are really important questions that we all have to engage in. Let me stop talking and turn it over to my two colleagues to explain what they understand and believe are what we mean when we say healthcare equity, and then we'll get into a discussion. So first, Juan, come on up, and pleased to have you here. Please welcome him to the podium. Thank you so much.
Thank you.
Good.
Thank you. All right. Wow. Thank you for those very personal stories, and just what a there's no better way to define health inequity than through personal narrative and those experiences. It is a pleasure to be with all of you today. Uh, Again, Juan Fernando Lopera, with Beth Israel Leahy Health. Um, it's actually a year ago last week that I started in the role as the inaugural Chief Diversity, Equity, and Inclusion Officer. And it's interesting, a year from starting the role, that I be with these two gentlemen here, because the two of the first phone calls I placed when I started in the role was Guy and Michael, to figure out how to do this work in collaboration, how to address issues like health equity in collaboration, and how to do it at scale, and how to do it with leaders who are in positions of influence, who can really have population level impact, and who do it with uh, with the heart, uh, based on those lived experiences. And it was literally, I think, one of the first meetings I had, and it was one of your first meetings when you came to our office in Cambridge for BILH. And then Michael, we had known each other from my days at Blue Cross of Mass, but one of the first phone calls I placed to figure this out together around health equity. was with Michael, and we'll tell you more about the work we're doing in collaboration through this recently announced Health Equity Compact. Um, but I go back to this question about what health inequity means through that lived experience, through the personal lens. I'm originally from Colombia. I came to the U.S. In 1990. Um, the story really starts with my late dad in 1988 when he took the treacherous trip of what took about 2 weeks through Central America. I actually recently, a few months ago, was going through old files at our house and found the itinerary of his trip through through Central America, Guatemala, Mexico, Rio Grande, and there's a 7 horas a pie, 7 hours afoot as he was crossing the Rio Grande, and eventually made his way to Boston, where he happened to have family, and did that to look for a better future for us. Uh, Colombia at the time was just a very different country. Definitely has made significant progress, but like many immigrants, we found we needed to find better opportunities, and so he made the trip. We reunited in 1990 when I came as a 12-year-old, and health centers hold a special place in my heart because as an undocumented immigrant. Uh, uh, Me and my family, it was the place that we could turn to for healthcare. It was a place that we could turn to where we could find people who could speak our language. And it wasn't always the case. There were many times when a 12-year-old or maybe a 13-year-old, 14-year-old, by the time I started learning English, I became that medical interpreter for the family. But it was that all those experiences combined as an immigrant, as someone who at the time was undocumented, who did not speak the language, who was predisposed to many chronic conditions due to our living conditions, who lived in crowded living spaces because that was the only way we could afford an apartment back then. Um, and to have family members who were part of what we now call the essential workforce. It was all of that really came to life when we saw what transpired during the pandemic and the peak of the pandemic in the summer of towards the summer of 2020, and as we saw places like Lawrence, East Boston, Chelsea, Brockton, those communities where sort of the perfect storm of conditions that we refer to as social determinants of health now. We have a term for all these things now, but it is basically it took a pandemic, it took the murder of George Floyd and many others to really wake us up to realize that we need to do something, that we need to seize that moment, turn it into a movement. So all of that is really what has guided the work, what has really uh, underscored the importance of leveraging the platforms that we have and the roles that we're in, the roles that many of you are in, to really place a focus on health equity, to invest in health equity at a system level, and to make health equity really next chapter in health reform. We have seen the evolution of healthcare in this country, uh, and we obviously have a long ways to go. But we've seen chapters, and Massachusetts has been really a leader in many of those chapters, starting with universal coverage, uh, moving on to um, what we now refer to as value-based care, and uh, and health equity is sort of the next frontier. How do we tackle that in a systemic way to address centuries-old systemic issues that do stem from systemic racism, that do stem from being more exposed to what we again now call social determinants of health. So it's when I think about health inequality, um, it is being able to address all those things. It is being able now to actually, as we did with COVID, be able to look at and stratify data by race, ethnicity, language, sexual orientation, gender identity, and show the significant um, the significant deficiencies of our healthcare system, and to be able to place the right resources to address those issues. Um, so health equity is really addressing those issues in a systemic way, and uh, and doing it really from based on lived experience, leveraging those who have been closest to the pain, which we get to see firsthand in our communities what they went through, and I think we can definitely uh, turn this into a movement. And I think I feel more optimistic than I ever have in my entire career in healthcare that we do have a chance at making health equity really that next chapter in how we transform healthcare. So I'll keep my remarks to that for the moment, because I know we'll engage in more discussion. But that's how I would define health inequity, and then health equity as sort of the next frontier. Thank you.
Next, if you'd welcome to the podium, Mr. Michael Curry.
So I think I'm sitting there a little overwhelmed right now because I was a theater person when I was in high school. And I wish I had an auditorium like this. So I'm like sitting there like, wow, this is amazing. So let me get over that for a second. I think when I think about the conversation we're having today, I think about, one of the ways that Guy started this conversation, and one of the ways when I do presentations on racial justice issues and health equity issues across the country, I always start the presentation by saying, when I was a kid growing up in Roxbury, my mother moved here from Alabama for, if anyone's ever read the book, The Warmth of Other Suns, Isabel Wilkerson's book, out of the Jim Crow South, for all this opportunity by herself, teenage girl, to raise her children. I was born here, Boston City Hospital in Boston. And I would tell people that in the beginning of the presentation, I said, I'd walk through my neighborhood as a little kid, and I'd see all my neighbors and my family members were dying of almost every disease at high rates and leaving too soon. I'd walk around my neighborhood, and many of us, if not most of us, was poor. I walk around my neighborhood and most of my uncles were incarcerated. So I was spending my weekends going to Norfolk State Prison, Walpole. I'd walk around my neighborhood, and if we ventured outside of our neighborhood to Cleveland Circle, Coolidge Corner, Faneuil Hall, we never felt comfortable. It always felt like we didn't belong there. And when we went to school, we were often in schools where there wasn't the same academic rigor as some of the people we may interact with who went to other schools, or our books weren't the same. Now, I'm not talking about the 1950s. I'm talking about the 1960s and 70s and 80s. Then I left my neighborhood and I go visit family in Alabama, Birmingham, Tuscaloosa, and they were living the exact same way. Then I'd visit family in Ohio and they were living the exact same way. Then I went to college in Minneapolis, St. Paul, and I'd walk around St. Paul and black and brown neighborhoods, and they were living the same way. And I was overwhelmed by that, to understand that nothing we experienced in Lawrence was just about Lawrence. And we could put our own context around that and say, why don't these people stop doing drugs, stop killing each other, eat right, pull up their pants, right, get a job? But that wouldn't make sense, because of course, all of us want to live healthy. All of us want to live a long life and raise our grandkids or our great grandkids. All of us want a great job, a great education, a great career. So something happened along the way that made that not possible for millions of Americans then and now. So to me, this conversation around health equity always has to be grounded in the truth and history. So one of the quotes that I often say is, it takes time for truth to catch up to history. Because we got a lot of history in this country, but all of a sudden in the last 2.5 years, the truth is catching up. So in my presentations, I'm always I call it quantum leap. I'm trying to jump back and forth between slavery, Reconstruction, wealth gaps, opportunity gaps, achievement gaps, because we don't connect those dots very well. And they all impact health. So if we're talking about driving our immigrant communities into the shadows under the last administration, if we're talking about impacting a woman's right to choose, if we're talking about discriminatory practices and policies, if we're talking about 20 years ago, the Institute of Medicine put out a report called Unequal Treatment that validated what activists had been saying in Lenox Street housing projects when I was a kid. Those activists, those miles used to walk around and say, well, doctors don't treat us the same. They don't think we have pain, right? They don't medicate us when we have pain. They don't want to give us drugs because they think we're all drug addicts. And my mother and some of the other older Black folks were shuttled by them like, well, yeah, they just militant. Then Institute of Medicine put out a report in 2002 that validated what they've been saying for generations. So I think as we have this conversation around health equity, one, let's not pat ourselves on the back too much post George Floyd and COVID-19, because there was a whole bunch of people who got here before us and nobody listened to them. And they were crazy and they didn't get invited to the meetings and they were marginalized and they were doctors and nurses and epidemiologists and researchers and community folk and parents who have been trying to tell us that we were not treating people the same. We also know, and Dr. Guy Fish said this very well, health centers were talking about social determinants of health before we had a term to call it social determinants of health. Jack Geiger, Count Gibson, they all understood that if you really want to do something, now that we call it the 80%, right? 20% of what drives your health status is the care you get, 80% is now all that stuff that I saw in my neighborhood. We didn't have healthy foods, right? We went to bad schools, and I say bad schools because we didn't have the same resources. So therefore, we had achievement gaps. We were often the first fired, least hired, underpaid. We couldn't get in unions then and now, arguably, right? The trades. So you can't not understand all that backstory and then make sense of health equity today. And I think that's where we are now, is this conversation around health equity is about affordability, pre-Affordable Care Act. How many people realize how many poor people, how many Black and brown people didn't have a health insurance card? And how unjust that was. To know that by the time you made a decision to go to a doctor, your pain was so bad that at that point, it didn't matter how much it cost. You had to walk in an emergency room, and now you found out you had stage 4 cancer. Right? So that's not equity, that you couldn't afford to get care. How many people went into doctor's offices across this country and didn't get equal care? Right? That's the quality of care, that we disparately were impacted. Another report no one ever talks about, Institute of Medicine, that came out around the same time, that I think is fascinating, that no one talks about, is To Err is Human. How many mistakes doctors make. And I don't even remember if that actually broke that data down by their patients of color, because I bet you that rate would be extremely high. So for me, I come at this with a personal story as well, and just want to shout out that people were here before us. And I think that's Carlene. Is that Carlene from MPHA? Who has within her movement of MPHA, Mass Public Health Association, she also has a Health Equity Now coalition. I just drove by you, Carlene, doing your press conferences at State House. I don't know if you saw me, because I was gonna honk and I was like, I'd be too disruptive if I cut her off while she's speaking. But I want to say this, and then I'll shut up and we'll talk as a conversation, that the question for me about health equity is also a racial justice conversation, because we got to solve for the achievement gap. We got to solve for the opportunity gap, the housing gap, the wealth gap. So it's when people ask me, why do you do this work at the League? Because you're really a racial justice guy. I said it really one and the same. That people live healthier, right? It's always that, I use social determinants of health, and I always morph that. I say social determinants of violence, social determinants of addiction or substance use disorder. They're all part of the same story. That's the intersectionality of all these conversations. How do we now get to the root cause of what makes people sick and what disparately makes people sick in communities like Lawrence? To me, I'm excited to have folks like Juan and Dr. Fish and Maisha Minter-Jordan and Jeffrey Sanchez and all these people, because they were there before most of society got there. Now let's see if everybody's willing to actually listen to them. Now let's see if the Dr. Betancourts and the rest of these folks who really been writing about it, talking about it, researching it, because we have attention deficit when it comes to racial justice and equity. Give it another year, people are gonna be tired of talking about this. So how much do we force this conversation? Do we, put something in the window to prop it open and say, no, you can't shut this conversation off. We got to pay for equity. We got to invest in equity. We got to be disruptive about equity. And I think that's where we're headed.
Thank you both, Juan and Michael, for your comments. A great way to kick this off. I'm going to ask you to do one more thing before we broaden the discussion or actually get deeper into health equity. You guys have been busy on this thing called the Health Equity Compact. In fact, the very first day that we met, Michael, you said, "Hey, I want to show you something." He brought out this nice glossy paper, a pamphlet that looked pretty impressive in the words that were on the page about really finally addressing health equity. So you've done yeoman work in advancing that with Jeffrey Sanchez and with folks from GSI and other places. Could you speak a little bit about what is the Health Equity Compact and where is it going?
So, one, I love doing this with Juan because we really like say the same things and we complement each other so well because we've been talking about it so much. I think it goes back to something we've all talked about. And I'm going to tell you, I'm 53, turning 54 this year. And I've been doing this work a long time. I was doing policy at Blue Cross Blue Shield, my first job out of undergrad. And I forget what year it was, but I've been doing it a long time. And I've been around, and one of the things I always noticed whenever I was in a room and issues of health equity would come up, or the disparities would come up, is that the folks often at the table did not reflect the communities impacted by the disparities. So there was no urgency to the conversation. So they said, well, we can't, equity's all, and I always say, equity's always competing with something else. We can't afford to do that. We have other priorities. Well, we will research it, we'll study it. But there's always something different when you have people with that lived experience at the table, because they say, no, we can solve it. I can see us solving for these things. So, and we're not, and the one thing I wanted to share that I'll share to answer your question is this notion of weathering. And I think it's fascinating. I talk about it all the time. And Juan, all of us sort of share these thoughts around weathering. When you can get so used to being sick that it becomes normal to you. So when I talked about all those communities across the country, we're all weathered to Black and brown people with high morbidity mortality rates, high asthma rates, high cancer rates, right? Living into the 30s and 40s, COVID-19, as we debated in front of the governor's COVID-19 vaccine working group, I'm sitting there and I'm gonna tell you, so oftentimes I'm the biggest nobody in the room. And I don't say that in sort of self-deprecation, but I say it because I'm sitting in a room with these really phenomenal researchers and doctors. Rochelle Walensky, the new head of the CDC, was in those meetings. And I'm like Michael Curry from Roxbury, right? And I'm challenging them on equity. And I'm like, well, you can't give out just J&J to Lawrence and Roxbury. And that's not equity. And they're like, Michael, we just need to put vaccines in arms. It doesn't matter. And they may not come back. And I'm like, but that's not equity. So there's always this thing about people have gotten so used to our communities being sick, and we've gotten so used to being sick, that we now have to have a vision. And I think that's what this Health Equity Compact is. It's a group of Black and Latinx leaders and a growing number of others coming together and saying that, no, we actually can see a different community. And that we're now in a place that we've never been in Massachusetts in my 20 plus years doing policy work, 30 plus years doing policy work. We've never seen Black and Latinx folks running, and I won't use the swear. We've never seen it. And in fact, in some parts of the country, they'd be in awe of Massachusetts. Some of our major hospital systems are run by Black and Latinx people. I'm now, after 43 years of Jim Hunt, my predecessor and friend, the leader of the Health Center Association in Massachusetts. Maisha, CareQuest, I can go down the list, some phenomenal leaders. And now we can marshal the resources, the energy, the passion to finally address these issues and unweather ourselves. So the compact is really that. Is how do you bring people together and say, okay, now you're here. We fought, somebody died for you to get these jobs. Now, how do you take that window of time that you're in this position and turn that into saving lives and unweathering ourselves? And I think that's what we've been doing.
That's right. And I'll just add that it really, we're very careful about how often we invite more legislation, uh, coming from the private sector, if you will, as I have in my career. This compact is looking to really advance health policy, advance, really codify health equity again into that next chapter of health reform, and it does take that private public type of commitment, collaboration. Um, in the case of health equity, our argument is we need people with lived experience who are in positions of influence to lead the way. If you think back to other chapters of health reform, it's been primarily white men with privilege who have been making really critical decisions. And if you think about even to today's health policy commission, it is primarily white men who are policy wonks, and they do great work, and they're amazing allies to this. But we need that lived experience there. We need more representation. So part of what the Health Equity Compact calls for is um, that we change that landscape, that we change the representation, that we address representation both in private and public. It calls for data to be collected, stratified by race, ethnicity, and other key demographics. It calls for more accountability. If you think about uh, other aspects of healthcare, there is an annual hearing on the cost of healthcare. There should be an annual hearing on health equity so that we can figure out how we advance it. And I see Colleen there. And so we need to continue to focus on these things and to codify these things. Workforce is a big challenge. Pretty much we're at full employment across the country and in Massachusetts. Um, but that's not the case for every community. We're at less than 4% unemployment in Massachusetts, but in our Black and Brown communities, there's double that rate. So how do we, from a workforce standpoint, where places like my organization has more than 4,000 job openings, how do we ensure that we tap into that talent, that multilingual, multicultural talent that's out there that happens to be underemployed, unemployed? How do we address issues like childcare, which is one of the major barriers to getting our communities back to the workforce? So workforce is another key component of this health equity compact. So we have the work, one of the key deliverables from this health equity compact, and we're doing it in collaboration with a law firm that is doing work for us on a pro bono services on a pro bono basis, is to develop a legislative outline that we start to bring to really the next administration, to say here are all the things that should go into a comprehensive health equity bill, because that's how we think of it. To really have that type of systemic impact, it needs to have all those things. We talk often about, geez, are we boiling the ocean? Well, we kind of have to boil the ocean to really have the systemic change that we need to. So that's where we are. We have we're working on this health equity compact to really advance health equity, to make that the next chapter in health reform. One of the key, another key thing that's coming out of this compact that we're very excited about, and we're working with the Blue Cross Foundation, is to conduct a study that quantifies the cost of inequality. And really, as much as many are moved by the moral imperative around health disparities, not everybody's moved by that. We need to put it into dollars and cents, so that the business community begins to care enough about health inequality to want to support the work that we're looking to achieve with this health equity compact. So recently, the Deloitte actually did something across the entire country, the cost of inequality, health inequality, and they said that if left unattended, health disparities will result in about a trillion with a T, 1 trillion uh, uh, unnecessary cost to the U.S. healthcare system by the year 2040. So that we need to localize and say, okay, what does it mean in Massachusetts, and how do we put that in front of the business community so they think about, well, that means that I'm going to have to pay more every year for the premiums, so that's a key component. There's certainly the moral imperative, but there's a financial implication to health and inequality that we need to add to the narrative. So,
and just to add to that scope of work for that report. So when we think about the cost of inequality, think about if you are an employer and you have a population of Black and Latinx and Asian employees and others, right? And they are disparately sick and they die early. What does that mean to your industry, your sector? That's real. And there are, I think, of many industries that I really interact with and all the hats that I wear, where a lot of people are dealing with high rates of diabetes or heart disease. So that's a factor in the cost of inequality. And then when we were all together 2005 and we were talking about health reform, and at the time I was at Blue Cross on that side of the table looking at health reform, the big conversation was the cost of healthcare in Massachusetts, curbing the cost, and the business community got on board. But we were looking at the cost of inpatient stays in emergency rooms. And if you wanted to curb the cost, we needed to keep people out of higher cost settings and get them into care, get them into preventative services. And that was really the movement in 2005, 2006. But we never thought about that in terms of race. So if you think about our highest cost settings, we're thinking about the highest cost care. We're also talking about Black and brown people who are disparately sick, availing themselves of that highest cost setting. So there is a lot to unpack, and I'm looking forward to whoever we select as the research entity to do this work, doing some groundbreaking work, because I can tell you, no exaggeration, I'm already getting calls from my civil rights hat across the country, people who are in this healthcare space saying, we hear about what you're doing in Massachusetts, we want to do that here. Tell us how you're doing it and keep us informed. The only other thing I would say, Dr. Fish, that I think is important, and I say this with Carlene on mine when I say this, it's interesting because I've been a dude who organized protests, wrote policy from a community perspective, not from an organization perspective, wrote legislation that became law. And, now I'm also in this role of being in an organization that has a seat at the table, or at least can demand a seat at the table. And what I would say is that the people who are in this compact are also swimming upstream. So let's understand, we talk about this in terms of race, that sometimes when you're a part of the system, then you have limitations on what you can say and do. That's true for them too. that they now have to push, we don't get to see it. But if you're Maisha at CareQuest or Juan at BI Leahy or Michael at the League, you're now trying to really push your own organization and your culture to embrace this challenge. And I would call them, and I don't exaggerate when I call them civil rights heroes and sheroes that we don't even know them. That really are saying, no, you're Manny Lopes, Blue Cross, we got to do this. We may not have thought about this, but we need to be on the front lines. And Manny, unfortunately, Andrew Dreyfus, the outgoing CEO, are on board. But I just want to underscore that this work is not easy. And when you're the DEI health equity person within these institutions that have historically been resistant to equity and change, you're doing civil rights work, right? You're changing systems in a way that people, particularly white men and some white women, have not been comfortable with. It's not comfortable there's something redistributive about change, right? There's something, sometimes, and we talk about this in racial justice terms, one of my mentors from Blue Cross, who said, you're asking people to invest in their own demise. Because that's how tribal we get, right? Is if we move money here, if we focus more on them, if we then that's more for me. And I know some of us think we have good hearts, but that's how natural this stuff has been baked into our society. We don't think about equity, which means I'm not going to give everybody, the rising tide is not lifting all boats. We got to go to Lawrence. This is not about Newton and Wellesley or Wellington or name the town. This is about Lawrence. because they disparately have a challenge that we need to address. So let's not throw out money to public schools, throw out money to housing, and then think that they'll all equally succeed. That's not the challenge. Lawrence need more investment.
Brilliant. Brilliant. Michael and Juan, you touched on so many things that I would have wanted to drag into the conversation, like, the underlying distributive economics of this. And we have an era in which we have people who are in DEI offices, and what does it mean to be in a DEI office and have to be a change agent within a power structure which was designed completely differently from what you are seeking as an important objective of who we are, how our companies are organized, and what their organizational goals and objectives are. So there's so much that you touched on that I don't have to really ask a lot of questions. But so at this point, and I think we're perfectly on time, really, to begin to open it up to those of you in the audience to engage with us on the conversation. So I'm going to ask, see if Julie is around. If not, then I'll do it myself. Oh, there she is. I want to take the microphone down, and we'll share 2 microphones up here. I'll come right here to you. And I think we have a hand up on the far, my right, your left. Thank you.
Thank you. Thank you, doctors. A terrific talk, and your shared stories were just amazing. Appreciate that very much. My name's David Roach. I'm with the Foundation for Business Equity. And my question to the 3 of you is around education. Is there a role for education in terms of in the hospitals with doctors, with nurses, with hospital administrators to help them understand what unconscious bias is, for instance, or Black history or Latinx history, just so that they have a better feel for what people are going through and have a little bit more empathy for that?
Maybe one quick thing is I would say yes, and having been a part of that work, I speak at MGH all the time, and their psychiatry program, and I talk to residents all the time when I get invited. And I think there's something to be said for trainings. I actually had a debate with somebody recently who was like, trainings don't work, right? I actually disagree with them. That I think it's like any of us who raise a child. Trainings are always you plant seeds, and it takes time to grow. And that's what consciousness is, right? However, I don't think that that's the true transformation. The quickest transformation is the training in a Juneteenth celebration or Black History Month or Latino history or LGBTQ history lesson. I think the reality is diversity matters. You just need somebody in the room to say, no, that's not right. Let's not do that. No, why are you treating that patient like that? That nurse, that doctor, that community health worker, whatever that role is. Because we don't have, or 5% of this country's doctors are Black. And most of them have to go through this narrow pathway of HBCUs. Same for Latino doctors. Until we finally open up the gate so that these brilliant people enter the field and can be in the room from the administration to the care, we will always have this problem. Because there has to be some checks and balances, and that comes from people sitting in the room. The last thing I'll say on that, and Juan has heard me say this before, I teach diversity, I coach diversity stuff all the time, in addition to my Mass League role. And I tell people, I sometimes get frustrated because I don't want to have to convince you that diversity is good. But one of the most powerful arguments I've made in the last year that I think actually sticks with people who don't get it is I say that there's a young Black girl in Roxbury, Dorchester, Southside Chicago, East St. Louis that's meant to find a cure for cancer, but we'll never know her. Because unless you're just into some white supremacist stuff and you really understand that talent is distributed equally, then there is somebody right now meant to do something phenomenal, but they go to a bad school, they've internalized racism, they're taught to believe that they're not as good as, they have trauma and violence in their communities, they're being incarcerated. And until we really take that seriously and then open up the floodgates of all that talent, we will probably always struggle with this because teaching is not enough.
Yeah, it's part of the toolkit, but definitely is just a starting point. And how training is done too. There's the bare minimum of expecting people, just like other trainings that exist around compliance or sexual harassment, where you then ask people to, okay, take this training and at least be aware of your implicit bias. But I go back to I think a more compelling story is the asset narrative, which is how do we. Yes, there's plenty of deficits. There's health disparities to address. There's implicit bias. There's micro and macro aggressions that occur in every institution. But there's a significant business imperative to this work, and we don't talk about that often enough because there is also a very compelling moral imperative, and we're in healthcare, and we should. That's the only thing we should care about. But the reality is, if you put it in terms of um, population growth, demographic changes. If you look at the revenue, if you want to put it in those terms, and the revenue opportunity from diversity, um, I think that also gives it significant sustainability to this work. That's how it really, quite frankly, started in this path of DE&I. I was before joining BILH, I was at Tufts Health Plan, spent 11 years there, and in 2015, I went to leadership and I said, "Look, we're missing out on 2.2 billion in top line revenue. We're missing out on about 270,000 customers worth of opportunity. And if you add health disparities and realize that if you can bring down medical costs, you increase top line revenue, you reduce medical costs, you got quite a margin opportunity." That's how I got placed in a role as the business. Actually, the title was business diversity officer at the time. So I've always, because I come from the business side of healthcare with lived experience, I've always married those two things, and I continue to do that today at BILH. First thing I did when I joined, I said, show me the patient demographics by rate, broken out by race, ethnicity, by hospital, so we can compare that against the service area demographics. And sure enough, every hospital, with the exception of Beth Israel Deaconess in Boston, had a big gap of opportunity. So this DE&I discussion needs to be turned into an asset narrative. It needs to be turned into um, the great opportunity that comes from DE&I while we address all the deficiencies that exist. But it needs to be those two things, not either or.
While you're getting the microphone to the back there, I'll just say that um, the concepts that we're talking about, whether it's diversity and inclusion or equity, if we're going to make any progress, have to be embraced by the entire institution, right? It has to be from the boardroom to the mailroom. And one of the things that I came across that I thought was rather brilliant was a scoring system for an institution that listed all the various aspects of the institution, right? About its bylaws, its policies, its procedures, who's on the board, who's in the management team, what is your promotion policies, all the way down through the institution. And then went the other direction to say, here is nominatively lip service, in other words, we call it nominatively achievement. Here is substantial initial steps, but it's still falling short. And here's full embrace of DEI. And being able to really put some clarity to what are the benchmarks and goals that we want throughout the entire organization. And it's incumbent upon leaders of organizations to understand, as Juan was saying, the economic imperative for businesses, not to count noses, how many of this color and that religion do we have, not to think just about whether or not you can open up a market and sell more hot dogs or Coca-Cola, but thinking about the fact that if you aren't embracing diversity and your competitors are, they're getting better ideas than you are, and they will eat your lunch. All right. So there's a competitive imperative for diversity beyond just doing the morally right thing to do because we want to distribute opportunity equally. So organizations need to embrace this from the top down. One of the things that we're doing at Greater Lawrence Family Health Center is we're actually working on training in DEI throughout the entire organization. I think I sent the microphone up the road there, but it'll come back down in a minute. Maybe Anne Marie, raise your hand there, can speak a little bit about what that experience is in trying to institute mandatory training in DEI in an organization of 800 people. But let's first go to the question we have on the side there. Hi, say your name and give us
My
your
name is
question.
Marissa Carrasquillo. I'm from Blue Cross Blue Shield. I work in health informatics. I'm also a graduate student at Regis College in Health Administration, and my undergrad is in public health. And I'm a Latina. So, as you can imagine, this is a very important title and subject for me. But all three of you mentioned the lived experience, that personal narrative, which to me personally is part of the whole patient care solution. And is this kind of part of the Health Equity Compact? Because it's such a vital part of health equity, that personal narrative, not just as individuals that are decision makers, but also for those that are not at the table, to take into consideration. Is this something that's part of the Health Equity Compact? Because it usually gets overlooked and it's vital.
Thank you.
Sure. I say almost organically it is because everyone brings those personal stories, those lived experiences to how we advance the work. Um, that said, we're also very cognizant of the fact that we are in a different place. We're no longer living in the projects. We're no longer living in places in the places where we were 3 decades ago. So we need to hear more directly from the community, and that's one of the very intentional aspects of what we're doing with the compact is going back out to the same places and hearing directly for those who are continuing to be in the struggle and hearing their personal stories. So I think that is for any initiative, that community voice is critically important.
And maybe two things. So one is I'm a big critic of advocacy efforts to say just go into the community and ask them what they want. Because I always say if you put my mother in the room, she won't even understand half of what you're talking about, right? All these acronyms and systems, because she's never even been educated on what the system is. In the communities I come from, they don't understand this stuff. And part of what we need to do, and I've said this in every table I'm in, is let's spend time. First, research is one. I've said to Karen Edmonds, the team at Harvard Chan School, I've said to let's spend time educating the community on what is research, basic terms. What I was very impressed by during COVID was I would go to the barbershop during COVID and they would start debating research topics at the barbershop because everybody was talking about vaccines and a clinical trial. And it was like it forced everybody to now have a shared vocabulary. And now everybody's watching television. They're trying to figure out how long before the virus would show itself. I think we need to approach a lot of topics that way. I think from this Health Equity Compact work, we made a decision about a week ago that we want to go back because I don't discount what happened first that led to this movement was I sat on every task force I jokingly say known to man or woman. I was on the mayor of Boston's task force, the mayor of Brockton's task force, Monica Burrell's DPH task force, the state legislative task force, a national task force on modernizing public health with several mayors and governors. And what I think we got out of some of those was we were collecting advocacy, community input. I didn't put it away. I still have that as a Bible that I refer to and I bring to those compact conversations. That being said, we need to then go out now that we've organized ourselves and then just in a room like this, receive feedback from people. But I hope we find a way to also lead them with something that is consciousness raising. And we don't just come in and say, hey, how do you feel? Because I just think that's disingenuous. And I know as a person who's relatively smart, that I've sat in some of these rooms, I didn't know what the hell they were talking about. So I felt, and I've said that to when I sat down with Karen Emmons and her team on a Community Coalition for Equity and Research, which I co-chair with Karen. I was like, before we start inviting community people in here to come look, meeting with researchers, let's spend 6 months just doing a study on what is research. What's the history of research? Let's talk about J. Marion Sims, experimentation on Black women, slaves. Let's talk about Henrietta Lacks. Let's talk about Tuskegee Civil. Then let's talk about the semantics, the language, FDA, life cycle of a drug, the cost. And she agreed, and they agreed at Harvard to do that. Groundbreaking work. Because now we enter that room, we feel like equals with the people who are asking us questions, or we're asking questions of. That was empowering. So I think that we have some work to do to figure out how to engage communities, and we need to take some models that have worked, and then we'll go out on the road and do that.
Yeah, thank you. This has been great. I'm wondering, Michael, you talked about basically the diversification of the health workforce as one really important strategic intervention towards meeting these goals. In your guys' minds, what are like 2 or 3 other most important, most timely strategic interventions that need to happen, that we need to start working on now to get there?
Trying to think amongst the long list. What are the top ones beyond workforce? I mean, we're kind of stuck at workforce. That's that's our existential issue at the moment. But I would, the one that is top of mind for me in a system as large as Beth Israeli Health, that has such a sizable purchasing power through our supply chain, and all the contracts that these large systems do, is the opportunity to truly move the dial on wealth inequality, um, by being by really doubling down on providing opportunities for minority-owned, women-owned, LGBT-owned businesses. It was one of the most mind-boggling things coming into the system to see how significant the opportunity is, and we're not alone. There's an opportunity across the board in healthcare and in every industry. Um, Michael and I had the opportunity to spend about 3 weeks ago in Denmark, learning about the significant opportunities for jobs created by the green transition. So the movement towards sustainable sources for energy. So we went there because Massachusetts is embarking on huge, multi-million dollar or more than $100 million in investments in wind farms, in many communities that are low-income minority communities. If we think about the work in the South Shore towards the Fall River as one of the places for the vineyard farm. Um, so there's so many opportunities like that for economic mobility, for jobs to be created within our communities, that we just need to be more at the table. We need to leverage our positions of influence to really address that economic inequality that exists. So that would be the other one, because we know how tightly connected wealth inequality is with health inequality. And there's just these institutions and these new industries. In the case of renewable energy, there are a lot of jobs out there. There's a lot of contracts out there, but equity for those jobs and equitable distribution of contracts is completely an afterthought. And that was my biggest takeaway from being in Denmark, that unless you got the right people at the table, it'll just be yet another opportunity that will miss our communities.
I was in the innovation space in Boston for 20 years, 20 odd years. A lot of work with biotech, a lot of work with pharma. Kendall Square, back in the day when I was an undergrad at Harvard, no one would mistake it for someplace you wanted to be. If you got off the subway there, you got right back on because it was scary. Um, and now look at it, right? It's amazing. And in the biotech sector, they also have a workforce shortage. Now, how do you have a workforce shortage? That is, you've got jobs that are open and you need them filled with skilled labor when literally 3 miles away, 3 miles, there are plenty of people who desperately want good quality jobs. The gap is that these people have never been given equitable distribution of education and job training. And then you come 30 miles north from there to a little place called the Merrimack Valley, and you add in some language barrier issues as well, right? So, this is what we call a market failure, right? You've got plenty of people who want to work, who need to work, and you've got jobs that are empty. So how do you solve that, right? You've got to invest in people. You've got to invest in communities. And you don't invest it because you're throwing money into the wind. That comes back to you and people who are working for you and increasing your economic gains by the work that you've already determined needs to be done and isn't getting done. So you're at a loss position. You make an investment and you get into a surplus, a gain position. It's pretty simple economics, but the short-term quarterly mentality keeps people from seeing that they need to make a longer-term investment. So here in Lawrence, we have plenty of people who want to work. We have, some skill gaps. We have some language barriers. We've got places like Beth Israel Lahey that's down, what was it, 5,000 jobs are open?
Yeah, 4,500.
MGB that's got literally like double that, 10,000 jobs that are open. The biotech sector that's got 10,000 jobs that are open. Folks, I'm no rocket scientist, but I know there's a solution in there. Mostly it's about transportation and job training, or transportation to get the job training, maybe some language skills on the side. We can solve this and everybody wins. So yeah, we really do have a need to think deeply about this. Thank you for the question, Jess.
Maybe one add to that would be for me. And again, I think there's so many. I wish I had time to write more because I would write a lot of stuff, but I'd write something about the lessons we learned from COVID, right? So one of the things I always say is we learn that we can actually partner together if we're forced to and do real good things. Like we can find vaccines, right? If we invest in it, if we work across the silos, we can work across big systems and community. If we partner with the Boston Black COVID Coalition and La Collaborativa and all these other groups, we knew we were supposed to do it, but the COVID forced us to do it. So one of the things that I felt like we learned was in this challenge of responding to a crisis, we need data, and we don't do a good job on data, right? Because as Carlene would tell you, because she was on the front lines of this, we didn't have access to data. We need to know John Snow 101. You need to know where the sickness is and where it's impacted so you can deploy the resources to address it. We didn't do that well because nobody wanted to fully address race and ethnicity data. I remember going back to the Division of Healthcare Finance and Policy. Anybody who's a policy person remember Lucinda Brandt. And I remember sitting in meetings with her as a Blue Cross person, trying to talk about insurance companies should collect race and ethnicity data. We still don't do that. I mean, even to this day, Carlin, I don't even think we still fully know the impact of COVID by race and ethnicity. So it raised the question. Some of my colleagues, some of these conversations will say to me, we got enough data. We know what the problem is. I always say that's BS because that's actually not true. I always, and I'm going to use this in racial lens when I say this. Folks didn't collect our data and tell our stories because if they did, they'd have to do something about it. So the best way to hide and not have to do something is not to tell the truth. Once you reveal it, then all of a sudden the people who are most impacted organize around it. And then other people, their compasses get adjusted. And they say, well, no, the way we should do something about it. So I think data matters. And that's why data is a part of this compact work, is how do we collect data and how do we make sure data is available. The other is data and education, which is I feel like we we don't really know the truth. That's not just data, that's just context we don't have. And until we have context, we won't ever be able to solve these really complicated problems that are very entrenched in American history. So we now need to have, that's why I love when I do a lot of history stuff, and people invite me in for 2 hours to just quantum leap between 1619 and 2022. Literally jumping back and forth between, and I'm digressing to say this, Doc, so forgive me. But one of the things I love in his presentation, Crispus Attucks, first man killed in the Boston Massacre. How many people knew that he was 6'2", and that John Adams defended the British soldiers in the attack on those men? And there's a backline to why those men were sort of rabble rousing, because it was about jobs or whatever. Most people don't know that the argument that was made in court that he was threatening, the 6'2" black man was threatening, because the average height was 5'6", 5'8". And that I could quantum leap that to Ahmaud Arbery, Michael Brown, George Floyd. And if you're sitting in the room and you're a young black man or woman, or Latino man or woman, you're like, okay, now I get it. This is not new. This has been baked in the pie of American history. And we've been perpetuating it for generations. We have to now be willing to give context to conditions. And I'm not sure, because it makes us uncomfortable to do it. I say the movie Sixth Sense, if anybody remembers, the classic line from that movie is, "I see dead people." So I use the analogy that we, just like the little kid didn't want to see dead people, because if he saw them, he'd be crazy. If he saw them, he'd be picked on. That's racism. That's inequity in this country. And I know because I've been that person since college, when you say it, people don't want to invite you. When you say it, they're like, oh, you talk about race too much, until George Floyd. When you say it, they're like, okay, do you have anything else you can talk about? Because we're uncomfortable with the truth. So we never solve it. So I think the other is just education and data.
I think we have time for one or two more questions. We're coming up on the top of the hour. So let's do the question there and then over on this side.
Thank you. Ellen Murphy Meehan from Lawrence General Hospital. Thank you, Guy, for bringing this illustrious group here to Lawrence. It really makes a difference. Thank you for coming. You mentioned measurement. There is no better place to come than Lawrence if you wanted to take a map of Massachusetts and look at the 351 cities and towns. And thank you, Carlene, for the great work you did. But by every measure, we are the largest community of color. We have the highest social vulnerability. If you look at the CDC's maps, we had the single highest COVID rate of any community in all of Massachusetts. And I think that those inequities are becoming clearer, as you pointed out. The other inequity that we've talked about is just how much resource has been dedicated to take care of this population. And we joke about the W's. Leaving the W's totally by Boston. If you took the time to measure what resources we have, and Guy is leading one of those major resources, the hospital is another one, we come up very, very short. And that's a conversation we've tried to have. And when COVID hit and there were no more federal dollars left and the hospital was going to default on their bonds, that they were strong enough to go to the public market to borrow because they needed to replace the operating rooms, we went to the city council and we said, can you pass a resolution asking the state to give us the money we need to keep the hospital services open? And one of the city councilors, Pavel Piano, said, so you get paid that much less? You get paid 73% of the average of every hospital in Massachusetts, but you're a leapfrog A and you have great quality and you do all the right things and you've got a 25-year employee running diversity, equity, inclusion, Virgilio Velez. You're doing everything right by our view. Is there something that we can do besides this? What can we do? Because there's a disequilibrium here. And you mentioned redistribution, and I just want to close by saying, this building wouldn't exist if it was just on the backs of what Lawrence could negotiate on its own. But 1 cent of every sales tax dollar is devoted to making sure schools like this get built for communities like Lawrence. And I guess I'd ask, what do you think you can do to help right the inequities? If you studied the spending by census tract or ZCTA or whatever it is in Lawrence, we would come up shorter than short. We know that we do. I've asked it to be measured many, many times. Look at every ZCTA score, look at every census tract and see what do we really have for resources for the most socially vulnerable population. And we are shorter than short. So I just ask what ideas you have about what we can do to bump that up so that maybe the healthcare institutions in Lawrence could look this good.
Because I've been working on these. First, I represent health centers, so that I could almost take your speech and just make it a health center speech because it's real. And we had to fight for rate increases, which I've been on the front lines of fighting for years since I've been in League 14 now. And we had a breakthrough last year with significant investments in health center rates, historic investments. But I can tell you, yeah, and that's actually credit to the health centers for that. But I'm going to tell you, it wasn't easy because folks have a natural distrust in these systems, even legislators. And they think, well, that's a lot of money. You're getting a lot of money. And they don't understand that you're still not getting the cost of the care you provide. But that's a hard argument for legislators. And I remember when I worked for Peter Mead at Blue Cross, Peter had me do a research when I was a young person in his shop. He said, look at the backgrounds of all 200 legislators. And he had me look. I was like, why would he need that? And he made a point to the Blue Cross leadership that most of them don't come from healthcare. They don't come from economic development. They literally are making policy about things that they don't necessarily, and that's how our system works. No discredit to them. But what it means is they need people to engage them, to educate them on this stuff, which is why it's so hard. And I know you do this already, but it's one, educating them, and then it's organizing and educating the public to understand, so that the city of Lawrence, the residents of Lawrence, understand that you're only giving 70 cents on the dollar for the care that you provide. You have to make that argument. They have to understand that argument, because for health centers, and we went through this, it falls on deaf ears. And I had to do, and my team had to do this when my first year being CEO. We didn't rely on their data. We got our own data. We literally hired and spent a lot of money with the CFOs of all the health centers to do this exhaustive study to show that they were not compliant. And Amanda Castlecraft at our gala just this past week, she jokingly said, as we gave her an award for the work that we did with her, she said, and Michael threatened to sue me. But you got to be willing, even with your friends and allies, natural, to push them and say, no, this is about our patients. It's not about the system. It's not about the hospital. It's about that patient that walks into my door, and you're disadvantaging that patient. And I need you to recognize that and invest in my community, my hospital. So I just want to say credit to you and our other community hospitals who are on the front lines, and you're disproportionately impacted by this disease, by diseases generally, and we need to pay you right.
Thank you. I think we have one last question right there, and then we'll.
Yes, good evening. Got a couple of good friends here. The first thing I want to say is this is an incredibly solid session you've done. The audience should have been far huger than it is, but you've got some very able attendees.
At our
in
next
your
session,
audience.
everybody bring 2 people, okay?
Right. A second thing, and this is picking up on comments all 3 of you made. A couple of people here know I'm a survivor. 6.5 years ago, I was told I had stage 4 melanoma and 6 months to live. And I have an incredible, Mr. Leahy, incredible epic record about myself, tying together the 6 doctors that are working on me. I think you know where I'm going with this, why I'm talking about this. When you want to quantify the cost of healthcare inequity, I believe that, and the first time I saw that medical record, it was at Leahy when it changed my career 25 years ago. What's in those, here's the question, what's in those medical records that we can use to quantify what's actually going on? Dr. Fish, we met the other night at the Lawrence Partnership with Luck, you may remember, but hearing the story about your wife's experience, boy, if we could get the medical records out of Epic and look at what's going on with each doctor. I was just thrilled when they had to save my life one evening that all 6 of the doctors had my medical record in front of them. That was pretty thrilling. But you can use that same information. You can use that same information, I think, to understand what's really going on here, not just doctor to doctor, which was raised by your story, but within the community, and how do you actually get to the cost of healthcare and inequity. Thank you.
Thank you so much. And I think, your point is really, really sound. Both Juan and Michael have mentioned more than once each data, right? We have to leverage the data that is there. It's been a hard time. When I closed my practice, I carted away 30 boxes of paper, even though my practice was one of the first ones to have a computer, but that was mostly for billing and trying to extract patient information out of it, like who are all my diabetics on my panel. It was really tough back in the 90s, right? And it was really tough. I was hacking and coding, but since electronic medical records are here, there is a lot that we can pull from them to do, and this would be sort of PhD level work, but it'd be really interesting, right? We should be sponsoring PhD level work to understand at a detailed level how healthcare is being delivered along those dimensions of race and ethnicity.
There was I'm glad you brought up that point. Part of not a Leahy, but Bethesda Deaconess Medical Center. This week I was having lunch with Dr. Tom Dilbanco, who's retired now, but he's was one of the founders of Open Notes, which is basically providing transparency to medical records so that patients can see what doctors are saying about them. That actually has turned into a movement that had now over the past say year or so, there's been a lot more attention given to using artificial intelligence, machine learning to comb through all those medical notes and make sense of it. And a research paper that was published recently of an academic medical center in Chicago, predominantly Black patient population, they looked into the medical records and stratified the data that they extracted by race, ethnicity, and found that words like difficult, non-compliant were predominantly used for Black patients. So there's a lot to unpack in medical notes that I think can inform and educate, right, exactly, and educate topics like implicit bias, so we can get the training in an educated way, in a data-driven way, to say, "Ooh, looks like this practice here could use, more implicit bias training, because look, the data shows that you're coding information about your patients in a discriminatory way."
Great. So with that, we're going to close out at this point on a couple of notes. The first note is an advertisement for our next event, which is going to be on restorative justice. I think, Michael, you spoke to the issues of being in schools and not being able to get the kind of education and advancement that you want, and then we have what we know in this country is what's called the school to prison pipeline. So once you enter that and you come out on the other end of the school to prison pipeline, particularly for Black and brown men, what are your job prospects? How do you get plugged in to gainful employment? How do you get insurance if insurance is through employment? How do you get housing if you have something on your record? So our next event will be Mr. Yari Tavares, who is the head of the Esperanza Academy here in Lawrence, speaking on restorative justice. What is a completely different way for knucklehead boys and girls, when they're in school doing stupid things like I did, to not end up in the carceral system and have those equal opportunities that they deserve be coming to them for them to lead full lives as well. So Yari Tavares, head of school of Esperanza Academy, Thursday, August 18th at 4:30 p.m. right here. And finally, before we close, I do want to have everyone put their hands together as I present our guests with a couple of mementos for their willingness to make the trek, come up here and help us think through health equity. Everyone, thank you so much. These are for you, Michael. And Juan. Thank you, everyone. Have a great evening.